topic for today is high dose Donepezil. See, we have come across this molecule called Donepezil for Alzheimer disease, dementia, but we haven't used it more than 5 or 10 milligram. Most of us. I did a pre-seminar survey on our group, and most of the people haven't used it. And if we want to use it, we would like to hear it from the expert. So Dr. Ravi is the second geriatric psychiatrist of the country, passed out DM from KGMU Lucknow, and he is the best person to guide us on this. So when we talk about Alzheimer disease, as far as use of Donepezil is concerned, we just know about preclinical Alzheimer disease, mild cognitive impairment due to Alzheimer disease, mild Alzheimer disease, dementia, moderate. So we have an anti-amyloid therapy that is coming up, which is not the topic of the today. The symptomatic therapy includes the acetylcholine esterase inhibitor. That is the primary therapy for dementia. That is donepezil, galantamine, memantine, and rivastigmine. Whatever I have observed from the slides, which was useful, which I found was in mild to moderate Alzheimer disease, 5 to 10 mg of donepezil they have written in the slides. We will confirm this with our expert on the panel. I'm just telling what we have seen there. And moderate to severe Alzheimer disease, 10 mg to 23 mg. So this is our cholinesterase inhibitors. We have donepezil, galantamine, memantine, and rivastigmine. And this is the theoretical part of it. But let's hear this from our expert, that where he has used, what he has used, and how it has helped. So this is the basic framework, like any other webinar goes, where to use donepezil, where not to use donepezil. So, and this is the recommendation from the expert group: start at 10 mg for 3 months. So this is what is written in the literature. But what is being used, we would like to know. So first of all, we'll start with the first question. Dr. Ravi, have you used donepezil 23 milligram in your professional career?
Yes, few patients I have used in some of the Alzheimer's disease patients, moderate to severe advanced stages. So yes, I have used. And donepezil, when you start using it, so initially we usually start with 5 milligram. That is another scenario. But elderly patients in India, we have to keep in check that what they are medically stable or not, and what is their body weight. So India, as per se, or Asian countries, we have lower compared body weight is compared to other countries. So that is more important. And the significant initial side effects are GI symptoms, but significant side effect on a longer run is anorexia. So if you are planning to use a higher dose of donepezil, the patient should be stable. He should not be frail, cachexic, uh, psychologically also stable, and all other medical conditions should be under control. And there should not be anorexia. And first and foremost thing is the patient should tolerate, or at least have tolerated 10 milligram of donepezil. Then only you can go to further higher. And obviously in moderate to severe stages.
Dr. Ravi, some of the participants may be very naive, who are not even aware about what is moderate to severe Alzheimer. For simple terms, can you tell them how do an MD psychiatry is supposed to know what is moderate and what is severe Alzheimer?
So, in a simple terminology, if I say that any kind of dementia, if you are going to assess or if you are taking history, so it comes under ABC, that is activity of daily living. The B is behavioral and psychological symptoms of dementia, and C is cognition. So, if a patient comes to you for the first time, index case, nobody has ever seen, and the patient's basic activities are compromised, so patient is already into moderate to severe stage, because basic activity like toileting, bathing, day-to-day routine, it usually goes in moderate to severe stage. So this is a simple clue to identify the person is in a moderate state. But if we go through further, like activity of daily living, then usually the instrumental activity goes first, then goes the basic activity. The patients are getting dependent on the caregiver, caretaker. The behavioral and psychological symptoms, as the disease progresses, the symptoms, incidence and prevalence increases. So initially it may be anxiety, depression. As the symptom increases, more psychosis and other behavioral part comes. So The psychological component, psychological symptoms are getting less and less, then behavioral component is more and more in moderate to severe stages. And cognition, obviously, we go through initial assessment, we go MOCA, MMSE, or all that. So when a patient is having MMSE score below 10 or below 15, so you consider it as a moderate to severe stage. And in India also, we have to modify the scores based on the education level. So it is always difficult, and many at the times the patient come in the moderate to severe stage only. So that's how it is a clinical clue that you can identify people with moderate to severe stages of dementia.
Yeah. When we talk about acetylcholine esterase inhibitor, in comparison to donepezil, there are three other things. Where, according to your practical experiences, do you recommend donepezil? Where do you recommend galantamine? Where do you recommend others?
So the major part with donepezil is that it is the most studied molecule, most evidence-backed molecule, and easily available. And it is also available in combination, fixed the drug combination with memantine, and that is the reason why it is used vastly. So donepezil mostly in Alzheimer's disease, mild to moderate severe. So any stage of Alzheimer's is not a contraindication for donepezil. Any stage you can use. Apart from that, if we consider other dementia, so mix Alzheimer's plus vascular, then also you can use. So there are certain reports that in mix Alzheimer's plus vascular dementia, it is beneficial. It is somewhat beneficial in small vessel disease like Biswenger's disease, but not in multi-infarct dementias. So Alzheimer's and mix Alzheimer's, you can use donepezil. Now, for the rivastigmine, because it has dual mode of action, and the studies and meta-analysis and RCTs also confirm that it has improves behavioral and psychotic component, modest benefit on a point score that is significant. So Parkinson's disease, dementia, dementia with Lewy bodies are the primary indication for use of rivastigmine. But rivastigmine is the only molecule that is available in transdermal patch formulation. So if any dementia molecule, any cholinesterase inhibitor you give to the patient and they develop significant GI not tolerating anything, then you can use rivastigmine patches in that particular patient. So particularly whenever, even in advanced stages of Alzheimer's, or when the, because Alzheimer's, it is not the same symptomatology, same pathology, same course and progression in each and every patient. It is not defined. So some of the Alzheimer's patients are also more behaviorally disturbed, more psychotic also. So in that case, you can switch over to rivastigmine also. If you are giving donepezil, but patient's behavior is getting worse and worse, and you cannot give psychotropics, so if there are limitations. If you cannot give psychotropic, you can switch to rivastigmine, cross titrate them, and you can use patches also. So rivastigmine has this kind of benefits. So that is why it is used more in behaviorally disturbance, more psychotic kind of dementia patient. Galantamine, it is the least studied molecule, but as such, it is said that when the patient is on galantamine, the attention and communication component is much more better because of this nicotinic receptor modulation, and somewhat benefit in apathy also. So attention, communication, somewhat apathy benefit also. So those patients who are more suffering through language and communication issue, attention issue, you can use galantamine. And there is, so guidelines say that you could not use two kind of medication together, but there are no as such contraindication. I have used galantamine with donepezil also, and after adding galantamine, the patient is more stable. Symptom, the behavioral part, attention, cognitive cognition part are slightly better. That shows that has biggest impact in the daily activity. So you can use. And the most important thing, so some of the patients have initial severe GI symptoms with 5 milligram of donepezil, and because of that, other doctors have said that कि ये patient tolerate नहीं करता है, we cannot give anything now. It is dementia. It will be like this. आप बस सेवा करो. So when this kind of patient come to me, I usually give them galantamine. Even though it is not advisable to break the tablet, by I give half tablet of galantamine, 2 milligram, then gradually increase to 4 milligram, then 6 milligram, then 8 milligram. The patient tolerates very well and they are stable on galantamine. So no as such big side effects. And in donepezil, when you increase the dose, GI symptoms can occur. So when you increase from 10 to 23, also the GI symptoms, anorexia increases. In galantamine, if there are, when you increase the dose, as such, I have not seen the GI symptoms.
That's very important thing you said, that galantamine on increasing the dose does not have that difference, but in side effects. But donepezil has. So that nausea, vomiting is a dose dependent kind of a side effect with donepezil.
Yes, in donepezil, it can be. Some of the patient has initial GI symptoms with the 5 milligram. So obviously, you cannot give that molecule or you cannot increase. So you have to shift. Either you have an option of transdermal patch. Rivastigmine orally, sometimes it is very notorious drug. So I prefer patches. So, and sometimes obviously the patch cost is little bit higher. We have Indian company also with the patch, so little bit higher, but it is much more stabilized. Or the peak plasma consultation is also good. The it is also preventive aspect in the delirium. Delirium superimposed on dementia. So when you are giving sustained release formulations or patches, then there is somewhat reduction in the incidence and prevalence of sundowning also.
That's important. So in reduction in sundowning. So you said that you have used in very few cases moderate to severe dementia donepezil 23 milligram. Do you think using donepezil 5 milligram plus galantamine versus increasing the dose of donepezil, what helped you more?
Yeah, I have seen that increasing the dose of donepezil. First of all, I would just want to highlight the limitations. Uh, our usually Indian patients are lower body weight, and the significant side effect of donepezil is anorexia or appetite loss. So when you start donepezil 5 milligram, 10 milligram, I want to give 20 milligram, 23 milligram, but already patient has lost 3 to 4, 5 kg within 6 months, and appetite is the family member will say कि पहले जितना खाते थे उसका 50% डाइट हो गया इनका, और बिल्कुल खाते ही नहीं है, और खिलाने के पीछे हमें 1 घंटा मेहनत करनी पड़ती है, तो उनको भूख ही नहीं है. So in such scenario, if I want to give 23 milligram as sustained, I cannot. So what can I do? And apart from that, if a patient is gradually declining cognitively, functionally, becoming more dependent, and I have seen patient that just a little bit higher dose, 5-10 milligram, can improve this component to some extent. So then I add another cholinesterase inhibitor. In that component, I usually prefer galantamine. And apart from this, when you increase the dose, GI symptoms, also you have to look into the cardiac side effects, bradyarrhythmia. If the heart rate is going down, then also fall risk, dizziness, syncope, so many things can happen. And if the patient is already cachexic frail, you cannot use higher dose of donepezil.
One last question before we take the audience question. Do you think acetylcholine esterase inhibitor, as promoted, donepezil, rivastigmine, galantamine, have major role in Alzheimer and do not have much role in non-degenerative dementias? Like you mentioned vascular, like you mentioned other dementias. Do you think that other etiologies of dementia, acetylcholine esterase inhibitors are as useful as much they are in Alzheimer's?
No, they are not useful. So acetylcholinesterase inhibitors are primarily useful in Alzheimer's disease because of the primary cholinergic hypothesis and pathway. Other dementia, we see the frontotemporal dementia, it is a fixed body, and it is obviously frontotemporal dementia. So the 3, 4 different variants, different presentations. So based on the presentation, medication varies. So it is not useful in frontotemporal dementia. In vascular dementia, particularly multi-infarct, patchy cognitive deficits, it is not useful. But what is useful? That is memantine, obviously. because memantine has the ability to reduce neurodegeneration, excitotoxicity, but even within 10 to 15 days of the stroke. So whenever there is a patient of stroke and vascular dementia or vascular event, you can give even head injury, you can give memantine. It reduces the neurodegeneration, apoptosis also. So that is the most important. And in dementia with Lewy bodies, that the donepezil can be used, no issue. But the most studied molecule is rivastigmine. So what guideline says is rivastigmine. So as per we stick in particular that aspect, we stick to rivastigmine because it has benefit in behavior, psychosis. So that is why rivastigmine is most studied and most recommended. If you are giving donepezil, no issue, you can also give, but obviously it is expected that you give rivastigmine. So other dementias apart from Alzheimer's disease, cholinesterase inhibitor has no role in frontotemporal dementia and multi-infarct vascular dementia.
What is your go-to drug for frontotemporal? Like you said, vascular memantine. What are the drugs
Hmm.
that you use in frontotemporal dementia?
So frontotemporal dementia, depending on the presentation, is it behavioral variant, frontal variant, language or temporal variant, semantic dementia, or PPA, primary progressive aphasia. So I usually, behaviorally, I divide them in behavioral access and behavioral deficit kind of dementia. So if there is a behavioral deficit, you have to activate the patient. And if it behavioral access, you have to make them calmer. So usually it is not advised that you give antipsychotic in frontotemporal dementia. But whenever there is behavioral access, you use antipsychotics, whatever, because in dementia, antipsychotic carries black box warning. So whatever suits you. Particularly, I prefer low dose aripiprazole and even quetiapine. But and each molecule carries pros and cons. So you have to individualize to particular patient. Also have to take into account the polypharmacy, comorbidity, what are the medications going on, what are the interactions. If the person has already fall risk, you give quetiapine, you have to explain. So these are the things that one should consider in mind. In behavioral deficit, if it is apathy, so you give dopamine agonist or something that stimulates dopaminergic receptors. So whatever molecule available, you can use that. But always keep in mind that when you give dopaminergic agonist or when you are increasing dopamine, you have to review within a month because I've seen patients going completely psychotic, going into manic, even in FTD. So dopaminergic agonists carry a big risk of switching to psychosis and pure behavioral difficulties. So in frontotemporal dementia, particularly those whose obsessive OCD wala jo circuit are affected from DLPFC to basal ganglia. In those cases, you have to give SSRI plus memantine. So it depends on the presentation, what molecule
Depends
you
on the
give.
presentation. Behavioral excess or behavioral deficit. Yes.
Hmm.
Okay. So I will take now the audience questions because there are 5 questions now. The first question is from Dr. Nidish. Donepezil has caused urinary hesitancy in one of my patient when I increased dose from 5 mg to 10 mg. Any way to manage this particular side effect while maintaining the dose?
Uh, First and foremost, that if the patient has developed this kind of symptoms just because of donepezil, we have to make sure because in elderly there are other issues, so many issues. So medical comorbidity, other organ symptoms, you have to exclude. And if it's just because of the molecule, you can reduce the molecule or continue with 5 mg, add something extra. You can add another cholinesterase inhibitor. This is how you can manage.
Dr. Madhur has asked, what dose of galantamine do you use?
So I have used uh, maximum I have used 24 milligram. It is recommended 24 to 16 to 32 milligrams. I maximally use 24 milligram and patients are tolerating. It is a
How do we
costly
start?
molecule compared to donepezil. It is a costlier molecule
How do we
compared to
start? At what dose we start galantamine?
galantamine is to be given 2 times a day. So usually starting dose is 4 milligram 2 times. But if I feel that this patient has tendency of GI disturbance or already on so many medication, already on so many medical comorbidity and a history of GI disturbance, then I break the tablet and 2 milligram 2 times, then 4 milligram, 2 milligram, 4 milligram, 4 milligram, 4 milligram. So I devise this kind of protocol for them, and they tolerate it well.
Hmm. Dr. Arushi has asked, can you repeat the sundowning point which you mentioned in delirium?
So whenever we give any kind of cholinesterase inhibitor, so obviously we are very much knowledgeable and about the reticular activating system. Okay, so the cholinergic acetylcholine has a major role in our activation. Obviously, memory, but attention and activation also. So whenever there is a cholinergic deficit, the sundowning or delirium is precipitating. And the sundowning is usually the initial part of delirium development. So usually whenever the stimulus goes down, the this kind of delirious symptoms develop. So there are studies which says that if you give a sustained release formulation, or if you use a formulation that maintains the peak plasma concentration throughout the day. So what happens when you give molecule in the morning? So there is a little bit higher peak plasma concentration, it gradually goes down, and where it goes down, you are giving in the morning, it is going down towards evening. So it studies says that you give sustained release formulation or patch, transdermal patch, that keeps the peak plasma concentration steady throughout the day. And there is a correlation okay, with this formulation, the delirium sundowning chances are less.
With sustained release formulation. Yes.
Yes.
Okay. Next question is, after what duration of 10 mg donepezil should we increase to 23? Can it be used with memantine? If the side effect increase with 23 mg, what to do next?
So, if a patient is on 10 milligram, tolerating well and doing fine, stable, there is no need to increase to 20. But if you feel that patient is not stable, cognitively declining, attention is going down, functional declining, and there are chances that the patient may benefit if the patient is tolerating well, then you go from 10 to 20, 23. Okay. Memantine and donepezil combination fixed dose drug FDC available. You can use that. Memantine can be used moderate. So guideline says that memantine can be used or should be used moderate to severe Alzheimer's disease. So when a patient is on 10 milligram and mild to moderate, you have stabilized the patient, but now the condition is getting worsened. Now you can add memantine fast rather than just increasing donepezil to 23 milligram. Give 2, 3, 4 months to work memantine, and if you feel that patient is stabilized, then no need to increase to 23. But patient is not stabilized, the decline is steady and it is happening, then you can increase to 23 milligram SR. Patient must Patient should have tolerated 10 milligram very well, and after increasing the dose, you should review within 2 months, 3 months, because appetite loss is very important, anorexia and cardiac side effects. You should be watchful for this.
Okay. Next question that has come up is from Dr. Ruturaj Kulkarni. He's saying that can we stop cholinesterase inhibitor once the patient progresses to severe dementia? Because the evidence mostly exists for mild and moderate Alzheimer's.
Yes, so when not to give. So de-prescribing guidelines are also available, and one should be aware of that. So when the patient is in the advanced stage, bedridden, even has the difficulty in oral intake, cachexic, frail, and extremely medically unstable, in that particular scenario, you can stop cholinesterase inhibitor, because in advanced stage or further, there are no benefit of cholinesterase inhibitors. There are no cognitive benefit. Mild behavioral benefit may be there, but obviously, cholinesterase inhibitor will make the person more frail, appetite loss, and so many other things, cardiac side effects, and so many other things. Yes, obviously, you can stop.
The Donepezil plus memantine we generally use in dementia. What are the major side effects we can think of while treating? Does the combination of two drugs can increase the risk of side effects? Donepezil plus
Yes,
memantine.
obviously. Yes, obviously. That is why if a person is tolerating, so consider the side effect in a different way. The GI symptoms, just the GI symptoms. So that is another scenario. There are side effects like cardiac side effects. There are side effects like anorexia. So if you are combining two molecules have the same side effect, so that will augment each other. So there will be more appetite loss. So in such scenario, but one molecule has a higher propensity, another has less. But those the donepezil, if you increase, then there will be more appetite loss. So obviously you have to consider risk benefit ratio. 5 milligram of donepezil and 12 milligram or 16 milligram of galantamine are very well tolerated. There is no appetite loss. Then you can consider continue both. Obviously cardiac side effects, rhythm, ECG, heart rate, you have to monitor. That is the issue, and that obviously in dementia it is no, non-reversible. It is neurodegenerative. What do you have? You have four medicines, so you have to somehow manage with this. And if you are prescribing medication, it should not cause any harm. So that is the biggest part, that do not harm. If patients are not getting better, please do not harm. So you have to keep that in mind. You can obviously combine two, but combining is very important when the only one molecule has significant side effect like bradyarrhythmia and appetite loss. So if donepezil has these higher chances, then you can reduce the dose of donepezil, add another cholinesterase inhibitor, and continue and watch a review every 2 months, every month, every 3 months.
Great. Can we combine donepezil and rivastigmine patches? Any uses or any added benefits with this?
Added benefits. So this is also a ifs and buts scenario. So if the patient is not tolerating donepezil but has benefit in cognition and functions with donepezil, then we have to give cholinesterase inhibitor. In that case, you can completely stop donepezil and start with rivastigmine, either capsules or patch. So that is more important. You can combine also. Sometimes what happens, even rivastigmine also, when you have started 3 milligram, then you go 4.5, 6 milligram, then patient now starts developing anorexia. So you cannot go beyond 6, but obviously you should go beyond 6. So what can we do? We cannot do any. So donepezil and rivastigmine combination, patient stabilize, appetite loss is not there, then you can continue. Obviously monitor for other side effects. And if this is not working, then shift the patient to galantamine.
Another question, sir, Parkinson, dementia, and behavioral disorder. Beside levodopa, what to be added for tremors and behavioral issue, especially mouth and tongue pucking movements?
Uh, So in DLB, so these patients are very extremely sensitive for hallucinations. So if the patient is regularly seen by or consulted by neurophysician, then keep these decision with them only. उनको ही करने दो movements के लिए. We are just managing cognition and the hallucination. Okay. But when you start using these molecules on your own, then there will be difficulty in liaison. So if in a private practice, don't do this. If there is involuntary movements, you know that this is Parkinson. You know that these are the molecule you can give. But when you are licensing with others, keep our area to particular limitations and let them do whatever they want. But when they use trixifenidil for these movements and tremors, then there will be higher chances of cognitive decline, hallucination, delirium. So in that case, we have to listen and ask them to stop because this is causing the patient a lot. If these molecules are not used, that is only just tremor. But if these molecules are used, the family will be in jeopardy.
If we move from 23 milligram, from 10 plus 10 combination of donepezil. Should we donepezil and memantine? Should we skip memantine? 10+10 से 23 जा रहे हैं तो memantine हटा दे क्या?
Why two? So memantine has its benefits in behavioral part, stabilization part. So obviously we can give memantine. The patient is not tolerating memantine. And if the patient has certain issue like a kidney issue, renal impairment, where you cannot give memantine. If the eGFR is below 50, you have to reduce the dose or ultimately stop if the eGFR is less than 30. So in the conditions or scenarios where you cannot give memantine, then stop it. But if there are no contraindication, continue moderate to severe stage. No issue. The both of them work together. Patient is more stabilized in behavioral part also.
Then any interaction of Alzheimer medicines with endoxifen, because endoxifen people are using for BPSD also, behavioral and psychological
No,
symptoms.
there are as such no contraindications. But I have
Have you
not used
used?
endoxifen. I have not used endoxifen for BPSD because just the financial burden.
Okay. So any other question anybody has? We are about to be done. So I'll wait for 1 or 2 minutes if anybody has any question. I would like to tell all the Cortex members that please understand that we as an MD psychiatrist, we all have read dementia from Kaplan, Lishman, but whatever we read in MD is much, much more different and lesser than what the geriatric people read. There are countable handful of DM geriatric psychiatrists in the country. I think Dr. Ravi would know. Hardly 20 or 30, maybe.
Yes, maybe 2025.
2025. And if you, any MD psychiatry, DNB resident, any MD psychiatry pass out, DNB pass out, if you are getting stuck up in any patients related to geriatric, dementia, geriatric depression, and you would like to take an expert guidance or let's say proper opinion, then Dr. Ravi is a very approachable. I have all myself referred few cases to him, discussed a few cases. He also gives online teleconsultation and the patient need not go to Ahmedabad where he's practicing, and you can definitely take an opinion from him. And it is helpful because his experience in galantamine and donepezil 23 is far more than my experience. That's what I feel. So he's very helpful, and he will himself say that many other MD psychiatry resident doctors are asking questions. Dr. Ravi, anything you want to say to our team?
So geriatric psychiatry is more like of management, liaison, and telepsychiatry because without telepsychiatry, geriatric psychiatry cannot continue or run. So majority of the follow-ups should be or are on virtual consultation because the elderly patients, family member do not have that much time that every time they can bring to me. And obviously, I'm in the Ahmedabad practicing here. So I have many patients in periphery and different cities of Gujarat, Rajasthan, MP. Even I have few patients in Bangalore also. I have patients from Bangalore. They discharge the patient if they are in Gujarat. They ask them to meet me. Even they are virtually consulting me from different cities of Gujarat. Even Mumbai, I have so many patients. So geriatric psychiatry, the accessibility is much more better because of virtual consultations. What I need, the patient's physic, medication list, comorbidities, and symptom profile, and what are the current. If I want, I can ask them to develop neurocognitive assessment locally, and then I can start. So I just need to confirm the diagnosis. And also I need to confirm the side effects and interactions. That is my job. I am the medication reducer. मैं दवाई कम करता हूँ, patient ठीक हो जाता है.
Okay. Thank you so much, Dr. Ravi, for the insightful session. And on behalf of Team Cortex and eSci Pharmaceutical, we would like to thank you for your enlightening discussion. I'm sure this is going to help. Thank you so much, Dr.